hear me? Okay, I can see everyone nodding. So
Yes.
thank you. So I want to welcome everyone to the SWOG Spring 2021 Surgery Committee meeting. I wish we were all in San Francisco where we're supposed to be, but hopefully next year we can be in person together enjoying the San Francisco weather. But today we've got a very exciting agenda for you with a lot of great talks. Just some housekeeping items. I, along with my Vice Chair of Surgical Committee, Dr. Flavia Rocca, want to welcome you to this session. Our Executive Officer, Dr. Elisa Kachnik, will give some opening remarks, after which we will have an invited speaker, Dr. Michael D'Angelica, who's the Enid Haupt Chair in Surgery at Memorial Sloan Kettering. And then we're going to have 6 separate talks on trials that are either ongoing or in development. There will be 2 ways to interact with us today. The first is a chat function. So if you have a question after the session, you can type in your chat question and I can read them out loud. Or if you want to actually speak, you can raise your hand and Matt from IMS will unmute you and will allow you to speak. The hand raising icon is on the bottom right of your screen next to the name of the participants. Both ways will be options for you. If you do get unmuted, please mute yourself after you finish asking a question to prevent any background noises. And we have a tight schedule, so I'm going to try to keep everyone on point in terms of time limit. Just to remind all the speakers who are waiting, all the trials and projects in development will be 10 minutes, followed by 5 minutes of questions. With that, I'm going to introduce Dr. Lisa Kachnik, who's the Chu Chang Professor and Chair, Department of Radiation Oncology at Columbia University, and our Executive Officer.
Hi, everyone. Good morning to, I think, everybody on the call, unless we have overseas people, I suppose. I am the Executive Officer for non-disease site groups, including surgery, imaging, and radiation. And so I'm just going to go over a few highlights of what are some opportunities for all of you and some things that are going on in our group chair's office. Next slide. So there's always lots of opportunities for committee members. And if you wish to become a member, if you're not already and are on, please, after the meeting, email myself or Dr. Ahmed, and we can help you with that. But even though we're a not disease site committee, there's still an opportunity to be a principal investigator on a new concept, and we can help you develop that. You can also be a co-investigator for a secondary endpoint, such as surgical QA, on any of the disease site developing protocols. And we're always mentoring and looking for liaisons on all of the disease sites. We're going to show you some great examples on the meeting today of secondary analyses. I have to say, out of all of 4 adult research cooperative groups, SWOG is by far the easiest and most nimble to do a secondary analysis, and there is a treasure trove of data and support that exists to do that. We also give travel grants for new and junior members, hoping that our fall meeting will be live, and that's a possibility. And then I'm going to go over some funding opportunities through our sister organization, the Hope Foundation. Next slide. Oops, this came out kind of funky, but luckily I have my own slides that I could read off of. So these are some of the upcoming deadlines, which you can look different when I gave the slides last week. But the first one is May 1st, and this is a very easy thing to do. It's a virtual grant writing workshop. And I know that some of my own faculty are looking to do it. It's a very simple application. And that's just helpful for preparation for young investigators to do future grant submissions. Now, the next one is a little more intensive and requires some background work. That's the Young Investigator Training course. So this, although virtual right now, but I'm sure we'll go back to live maybe in the fall, is a multi-day, very intensive workshop where we will teach you all about SWOG, all about writing a protocol, and this is a little bit competitive. You come to the table with the application with an initial concept that hopefully has been vetted and supported by a disease site or a multimodality group such as ours. So if anyone's interested in any of these things, again, you feel free to contact Dr. Ahmed or myself. The next one I actually just did a review for last week, and the next round is due July 1st. That's the SWOG Hope Impact Award. This is a 1 to 2 year project that provides up to $250,000 for both investigator salary and to cover some of the work. And it's really anything that might translate into a scientific discovery or lead to informing a new trial. We talked a little bit about secondary analysis. Just come to us if you have ideas. We could help get that through. Next one is a seed grant, so a SWOG Early Exploration and Development Fund, and that's $50K. They give these out twice a year. The next one's July 1st for the application, and this is for preliminary findings that might translate to a future clinical trial. So maybe a biomarker that you're trying to validate, or even a laboratory finding that might inform a new investigative agent. So if you have ideas, please. And the last one on here is the, I know, got the wheel of death. It's a VA integration and support program, also up to $50K. And this is like to meet or research from a VA. We have a sort of wide range of VAs that are part of SWOG. Does anyone have any questions? Maybe you can email me and I can put my email in the chat during the next slide. So things I did not know that I've learned recently. So the only group that collects Social Security numbers. I did not know that, but why is that good? That's good for leveraging Medicare data. So from a surgeon's perspective, and I'm a radiation oncologist, and same for me, if you're trying to look at long-term toxicity, here's SWOG is your treasure trove, because you can match your trial Social Security numbers to Medicare data, and soon to be all payer data, I heard in my meetings over the past week. Next slide. So our 4 adult cooperative group chairs have been meeting regularly with our NCI director, who's definitely a fan of clinical trial research, which is great. And he's very interested in developing concepts that have cell-free nucleic acids. And I was even like, well, what's that? I go, the rage right now is all about circulating tumor DNA. Well, now his rage is about cell-free nucleic acid. And basically what that is are fragments of DNA and RNA that reflect the genomic features of the tumor where they come from. And there's some data to suggest that tumors release this into the bloodstream, and it could be used as a potential biomarker for the development of cancer, but also to look at treatment effect. And I just show you on the right, this company that's kind of leading the way in the research behind this and building large databases to kind of do AI algorithms for predictions of cancers is Grail Science. And this is one of their open trials that's on the right called the Pathfinder. And it's basically open at some of the major academic institutions around the country, and it's accruing right now. But just in sort of thinking about trial development, you are all about something to consider. Next slide. Does anyone have any questions now? You can also put them in the chat for me. and I'm happy to respond to them that way, and I'll put my email in the chat.
Thank you. Thank you very much, Lisa. As Dr. Kachnik said, you can contact myself or Dr. Kachnik directly if you have questions regarding those opportunities. So we're very honored today to have Dr. D'Angelica as our guest speaker. For those who are not familiar, he's internationally recognized hepatobiliary surgeon. He's the Enid Haupt Chair in Surgery at Memorial Sloan Kettering Cancer Center. And Michael has been very passionate about hepatic intraarterial chemotherapy for metastatic colorectal cancer and other indications. In fact, he, along with colleagues, have organized a national consortium to bring together high-volume institutions that want to develop concepts utilizing hepatic artery chemotherapy for metastatic colon cancer and other diagnosis. There was a time when this was mainstream, and it kind of has fallen off the grid for a while, but now with data that's emerging from Memorial and other institutions, people are reinvestigating the benefit of utilizing hepatic artery chemotherapy as an adjunct to surgery for patients with metastatic liver disease. So with that, I'm going to turn the mic over to Dr. D'Angelica.
Thanks, Cy. Hopefully you can hear me well. I see you guys have a packed schedule, so I'm going to try to move this along. My goal of this talk is not to propose specific trials, although we'll end a little bit about highlighting our consortium and some obvious, I guess I would say, targets for trials. But really, my goal is to provide a history of this treatment, how it has sort of come, gone, and come back, and the data behind it that a lot of people don't know. I guess I should give apologies to the few people on this phone call who've trained here at Memorial who will know these slides well. But anyway, let's move forward. Next slide. So point number one, this is far from new. You can hit enter or something, the next slide, and it'll highlight 1984. I was a junior in high school in 1984. This therapy's been around for a long, long time. I remember getting a review on a paper I submitted, and they called this a new and experimental therapy, and I just couldn't stop laughing at the reviewer, who obviously didn't know much about this. Next slide. Basics of the rationale for this. It's actually a really elegant physiologic model of delivering high-dose chemotherapy to an organ without physically isolating that organ. We know from studies in the 1950s that the metastases are perfused by the hepatic artery, whereas the liver has a typical dual blood supply. And after many pharmacokinetic studies, some drugs, and for us that's floxuridine or FUDR, we know are, when given through the artery, are extracted nearly entirely by the liver, which allows two things. Number one, it allows minimal to no systemic toxicity, which then secondarily allows you to give other drugs in a systemic manner as well. And of course, biologically, this group really doesn't need an introduction to the idea that certain cancers can certainly be regionally confined to an organ, and colorectal cancer is a typical one confined to the liver. Next. So again, not new or experimental. It was abandoned in the early 90s. It was actually quite popular in the early 80s. There were challenges with administration. I'll get into this. There were challenges with biliary toxicity. And then for colorectal cancer, you know, oxaliplatin, irinotecan, and some targeted antibodies, EGFR inhibitors and anti-angiogenic antibodies came around, and people said, well, we don't need this pump anymore. And that's really what happened in most institutions. And in fact, it is not easy. It's not like just giving a drug the way most people do. It requires an operation to place a device. There is a very unique and potentially disastrous biliary toxicity associated with it. And it requires experience and a team, not just a surgeon, not just a medical oncologist. You need a group of people to do this together. Next. So a little bit about surgery. The main point is it does require an operation. Regardless of whether you're doing this robotically or through an incision, you have to put a device into the gastroduodenal artery. You have to make sure that it perfuses the liver and nothing else. Like any operation, there's potential for morbidity, be it infections, be it injury to vessels. Anybody, all the surgeons on this call will appreciate that any operation has potential. And this is one hurdle. I'm not going to spend a lot of time on this, but just to make the point, it does require an operation. Next. Very briefly about data from this, which unfortunately has not been updated in the last 15 years. There are pump failures. There are technical problems with these pumps, and it's a number of things that can happen. In general, about 90% of pumps work within a year, and at 2 years, about 85 of them will be working. Early complications are common and occur in about 1/5 of cases, but almost all of them are salvageable. Most of them are extrahepatic perfusion, which require embolization and pretty rapid repair and use of the pump. And we do know that there are some technical issues associated with complications. We know that experience matters, the surgeon experience as well as use of this over time. You know, we've been doing this since the 1980s, so it is very second nature here. But for the programs that are developing, there are lots of potential problems that improve with experience. Next slide. Biliary sclerosis is a serious, serious problem. It really dissuaded a lot of centers from doing this. It is the one toxicity. It actually is not toxic at all to the hepatocytes. It is toxic to the biliary epithelium. Some of these patients can require stents. Some of them can have disastrous complications. However, the great majority resolve with steroids in the pump. We routinely give steroids in the pump based on a randomized trial that showed less biliary sclerosis done many, many years ago. And the risk of serious biliary sclerosis is probably in the 2 to 5% range. It is definitely higher in the context of a liver resection when you're doing this as an adjuvant therapy. Next slide. This is just some data. I don't know if this pointer works, but if you can look at the bottom here, in patients who've undergone a liver resection, it's about a 5% risk of significant biliary sclerosis requiring a stent. In unresectable patients, it's much, much lower. It's typically 1 or 2%. There's something about the liver resection that contributes to the biliary sclerosis. And this is a serious number, but you know, this 1 or 2% is probably the risk of bowel perforation with Avastin. You know, and certainly the neuropathy associated with oxaliplatin is much, much higher and debilitating. So this is the one price to pay with pump chemotherapy. Next slide. This is for the medical oncologist. This is not meant to be studied or really looked at in detail, but dose modification is incredibly important and experience it in doing it. And if your LFTs go up, dose reductions are essential. And this is really the key to doing this. There's an art to this. It's not as simple as this algorithm that's given here, but just to make the point that monitoring this dose is not simple and requires some experience. Next slide. When we talk about pump chemotherapy now, people get confused. It is very uncommon that we use pump chemotherapy alone. We have learned, and I will show you the data in a second, that combining systemic chemotherapy and certain antibodies can be very effective. And that's essentially what happened when everybody abandoned the pump for systemic therapy. We basically combined it with systemic chemotherapy, and Dr. Nancy Kemeny deserves all of that credit. Next slide. So let's talk about unresectable disease next. So these are data mostly from the 80s and 1990s, just to show the early data on response rates and early assessments of efficacy for unresectable metastatic colon cancer. And you can see that if you give pump chemotherapy or systemic 5-FU, because that was the only chemotherapy at the time, you essentially double the response rate. And this obviously does not apply to the systemic therapies of today, and it actually doesn't apply to the pump chemotherapy of today. But just as a basic assessment of the efficacy, FUDR alone has response rates that are as good as systemic therapy today. And this is a long time ago. It nearly doubles the response rate of 5-FU. Next slide. What then happened is a number of trials were done, mostly single institution, some European, that really confused the issue. And you can see all these were trials comparing pump and systemic chemotherapy for unresectable metastatic colon cancer. Typically, this was pump alone and systemic chemotherapy alone. There were all kinds of problems. The trials were very underpowered. They were often done with 5-FU in the pump, which we know is not very effective. It doesn't have that high extraction rate, some of them. Many allowed crossover, which can be an issue. Some showed a difference in survival, some did not. Meta-analyses were done of these trials, which I think is a very faulty analysis because they're extremely heterogeneous trials. And this, I think these trials contributed to some of the loss of enthusiasm. But I'll show you the updated data. Next slide. So this Nancy Kemeny said, well, with all these trials, with all these problems, I'm going to do this in the best way I know how. And again, this is not necessarily relevant to today's therapy, but it's proof of a concept. And she allowed no crossover, randomized patients with unresectable disease to pump an FUDR alone or systemic 5-FU. And this, of course, nobody knows these data that got lost in the annals of oncologic trials that get ignored over the years. Absolute proof that in unresectable disease, FUDR alone is better than systemic chemotherapy back in the early 2000s. Next slide. So what about modern systemic chemotherapy for colorectal cancer? Well, first of all, it's no longer modern. Nothing's changed in the last 20 years. Unfortunately, immunotherapy has not been a great advance for colorectal cancer. Hopefully it'll come. But with oxaliplatin and irinotecan, we now know response rates are what FUDR was alone, 50% or higher. Median survival is generally between 2 and 3 years for metastatic colon cancer. But the problem with this disease that is never discussed is that the median time to progression on first-line therapy for colorectal cancer is less than a year typically. And once you get to second-line therapy, response rates are less than 20%. So efficacy in the second line is very, very limited. All the improved survival is based on your initial response. Next slide. So when did we know we were onto something? Well, while everybody was giving up the pump, Nancy Kemeny said, well, I'm going to keep doing this, but I'm going to add these new drugs. So this is a very early phase 1 trial done at Memorial Sloan Kettering, 38 patients previously treated, not necessarily progressing, but previously treated with pump and irinotecan. So I remember I told you, previously treated patients are going to have a very low response rate in second line. And we noticed a response rate of 75% and a median survival, having already been treated, of almost 2 years. And so this was a really good sign that we were seeing some efficacy as we combined treatments. Next slide. Like good oncologic doctors, we then started throwing more drugs. And again, this was pump chemotherapy combined with oxaliplatin and an irinotecan in an early phase 1/2 trial, about 50 patients. And what we noticed was we could obtain amazing efficacy. In the first line setting, the response rate is nearly 100%, and the survival, 48 months. Now, survival in young, healthy patients can certainly be biased, but response rates cannot. And so everybody responds to the point where you wonder whether the pump is functioning if they don't get a response in the first line. And even in the second line setting, most of these patients had just had 5-FU. The response rates were extremely high. And we also noticed that we were with these high response rates, we were getting a lot of people to resection. Next slide. Now, this is probably the most important slide I'll show you. For any oncologist on this trial, they will know for patients with almost any cancer, refractory to all therapy, they pretty much go to the phase 1 clinic, and response rates in the phase 1 clinic are very low, in the low single digits. You have to get very lucky in the phase 1 clinic. So we get all these patients referred to us who have all known therapy for colorectal cancer. And we basically treated about a little over 100 of them, some with some extrahepatic disease. And the response rate, again, in people who had no options for chemotherapy whatsoever, was 35%. Median survival, which is probably biased, these people had lived a long time, they were young and healthy, and they were able to fly to New York City to come for this therapy. They were living a long time. But this response rate, we cannot predict this. And I tell you, if I gave this slide with some novel immunotherapy, this would have been published in the New England Journal, but we couldn't publish it anywhere. We had to publish it in the Journal of Surgical Oncology. Next slide. Okay, so conversion of resection. This was something that we got very interested in. With systemic chemotherapy, the rates of conversion are all over the place. The definitions are all over the place, and it's very poorly studied. And we really wanted to study this. Next slide. And we needed to define what is unresectable, what has to happen to become resectable, what counts as a complete resection. And most studies do not at all define this. It's a very poor set of literature once you dig into it. Next slide. But we do know, at least in some hands, when people have felt to be unresectable and then they convert to complete resection, the long-term outcomes, while worse than the initial resectable, are pretty good. You know, long-term survivors who are probably cured, 5-year survival similar to initially resectable patients. So it does have potential. Next slide. And even in the most modern publication I could find on this, you know, with the, you know, really throwing the systemic kitchen sink at this disease, high response rates, reasonably high conversion rates, but these papers provide no definitions. I have seen papers on conversion to resection where the median number of tumors was 2. It is very uncommon to find unresectable patients with 2 tumors. So this literature is largely useless in my mind. Next slide. So in a trial that we did, we really sought to figure this out with pump chemotherapy. A prospective phase 2 trial, single arm, defined unresectable. And I can tell you, for the surgeons in this group, these are truly unresectable. Tumors involving all the inflow or all the outflow, or there was just no 2 contiguous segments to leave behind. And these were bad patients. Nearly all of them had synchronous disease. 2/3 had prior chemotherapy. The median number of tumors was 13. And we were able to convert about half of these to resection. There's a lot of details in how we did this, but many 2-stage resections, much use of intraoperative ablation. And so let me show you the outcomes. Next slide. This is a survival curve, and I just want to, this is 10 years out here. This is 5 years out here. This green line is all comers in this trial, 64 patients. These are not previously treated, and these are previously treated in this bottom line. And you can see this curve looks a lot like a patient with resectable disease. The median follow-up was 81 months, and the median survival was almost 4 years. 5-year survival, 36%. I should mention very briefly that we used Avastin early on in this trial, and the biliary sclerosis rate was high. Based on this and a number of other trials, Avastin is no longer used with the pump. I'm not going to talk a lot about that, but Avastin is not usable with the pump. Next slide. And so we then started to focus on the people we got to resection, and this is a landmark analysis comparing those who were resected to those who weren't. But much more important than these sort of statistical slides about long-term survival, of the 64 patients on this trial, 9 were NED. 1 had a complete response to pump chemotherapy and is alive almost 10 years later now with no recurrence. 5 underwent resection and never recurred, all of them with at least 5-year follow-up. 3 recurred but got repeat resections, and all of them are alive and free of disease with 5 years of follow-up from the last resection. So we think we've probably cured about 1 in 6 or 1 in 7 of these patients who are generally felt to be incurable. Next slide. So I'll move on to adjuvant therapy. Go ahead, next slide. We think we have effective adjuvant therapy, but we don't. These are all the trials on adjuvant therapy for resected metastatic colorectal cancer, most with limited disease. We know that 5FU adds nothing if you look at overall survival. We know that if you compare FOLFIRI to 5FU in the adjuvant setting, there's no difference at all in anything. We also know that when you give FOLFOX in the perioperative setting versus surgery alone, there was an initial improvement reported in progression-free survival, but no differences in long-term survival. And for reasons that are still a mystery to me, this has become the standard of care in the United States based on negative data. We also, in a very interesting trial, in the new EPOCH trial, know that if you add cetuximab, they actually do a little bit worse in terms of progression-free survival with the addition of an EGFR inhibitor. So adjuvant therapy does not work in the context of easily resectable metastatic colorectal cancer. That's just a fact. Next slide. And this is perioperative FOLFOX versus surgery alone. Long-term follow-up. This is the standard of care is to give FOLFOX. I'm not sure why. Because this is the trial. Now, people will tell me this was not adequately powered with 340 patients. Well, I usually argue that by telling them that if this was a 700-patient trial, it would have been stopped early based on this p-value and at halfway through the accrual. So this is a very, very negative trial. Next slide. So this is data that you probably heard about but don't know well. Published in 1999 initially in the New England Journal, Nancy Kemeny randomized patients to pump and systemic 5FU to systemic 5FU alone after complete resection of limited liver disease. Next slide. And these were the reported data in the New England Journal. positive for 2-year overall survival, very positive for 2-year hepatic disease-free survival, and borderline significance for disease-free survival. This was heavily criticized, honestly, in very unfair ways. I've heard people personally accuse Nancy Kemeny of designing this because she knew that there'd be a difference at 2 years. This is just a positive trial published in the New England Journal of Medicine. Next slide. The more interesting thing about this is to look at the real long-term updated survival. This was published in a letter. Some of these were just reported as numbers in the letter, but some of them were actually figures. This is the long-term overall survival. And you'll notice the p-value doesn't quite get there. And I'm going to show you why I think this is a trick of statistics, because if you look out here at 10 years, you nearly double the 10-year survival. But because this curve touches a couple of times along the way, I think it doesn't quite make the p-value. And the reason why I think that's real is based on the next slide. Next slide, please. This is the overall progression-free survival. And remember that pump can only control the liver, right? They've all got systemic chemotherapy. And you can see a durable difference in long-term overall progression-free survival. And this, if you're progression-free out here, you're cured. So this is very real difference. Next slide. And if anybody believes that controlling the liver disease, and surgeons have gone to great lengths to clear liver disease, but if anybody believes that clearing the liver disease and keeping the liver free of disease impacts overall survival, adjuvant pump can certainly do that. This is the difference in hepatic progression-free survival, which is very dramatically different. You don't need to be a statistician to see this difference. Next slide. This is a very, this aside, I emailed you about this trial. It was a SWOG trial, actually. This, I have to correct this, a very old SWOG trial done not by Nancy Kemeny, but her sister, Margaret Kemeny, who's a surgeon. A very small 80-patient trial also showed pump chemotherapy versus surgery alone. Very good signal that disease-free survival is different at 4 years, and definitely a big difference in hepatic disease-free survival. So a second trial largely forgotten. Next study. Next slide, sorry. Now, we've done a number of phase 1 and phase 2 trial in the adjuvant setting. I'm not going to show you all of those details because we don't have the time. But if you look at these top lines, these are a combination of trials, 2 or 3 done since 2003. And this is just natural history data from Memorial Sloan Kettering on single-arm trials. You can see 5-year survivals of nearly 80%, 10-year survivals of 61%, with very mature follow-up. You can see the number at risk here. So very promising in the single arm. Next slide. We then published this paper in the JCO, which was a retrospective propensity score analysis comparing patients at Memorial Sloan Kettering who either got a pump or didn't. There's a lot that goes into that decision. A lot of it is patient-driven. Some of it is oncologist-driven. But when we do the best we can to sort of in hypothesis-generating data, there is a very big difference in adjuvant pump versus surgery and systemic chemotherapy alone. This was all quote-unquote modern systemic chemotherapy, but you see a median difference of 2 years. And the most interesting thing to me is that no matter what subgroup you look at, there's a difference. Look at the p-values. No matter how many tumors you had, no matter what your nodal stage was, whether it was synchronous or metachronous, the only group that we couldn't really see a difference was those patients with extrahepatic disease. And it is interesting that if you look at these differences in survival, it is the earlier stage patients who appear to get the larger benefit from pump chemotherapy than the higher stage patients. This got a lot of attention because it was published in the JCO, unlike our refractory paper, which was published in a surgical journal. Makes me kind of laugh. Next slide. And Sep is on this phone call. She's published 2 of these things. So people will often ask about sidedness and RAS status. Is there any group that may not benefit from the pump? This is a little hard to follow, but adjuvant pump is associated with improved survival independent of RAS status. If you look at wild type, you see these 2 lines are different. If you look at mutated RAS, these are different. So it works independent of RAS status. Next slide. It also, in a similar analysis, works independent of whether it's a right-sided or a left-sided tumor. So we really have trouble finding a subset of patients who don't appear to have an associated benefit with pump. Next slide. I want to show this. This is in Press in the Annals of Surgery. Remember that in the new EPOCH trial, where patients were randomized after resection of liver metastases to systemic chemotherapy with or without cetuximab, we did the same. It was a negative trial, and actually the progression-free survival in that trial looked worse with cetuximab. We also did a systemic, a trial of pump with or without an EGFR inhibitor, in this case, panitumumab. It was a randomized phase 2, single institution, all KRAS wild type, pick the winner design, and there were enough disease-free patients in the panitumumab arm to deem that a very interesting arm for further study. And so even in the context of the pump, EGFR inhibitors seem to be potentially beneficial, unlike in the context of systemic chemotherapy alone. This is a fascinating trial. It's in press in the Annals of Surgery. It should be out soon. Next slide. So just very briefly, I try to do this as quickly as I can. First-line therapy has response rates of about 100% with pump chemotherapy for unresectable disease. With systemic chemotherapy, maybe 50% with standard first line. If you do FOLFOXIRI, it's 60, 70% maybe. In the second line setting, you go from responses of 50 to 75% with pump chemotherapy to less than 20% with systemic chemotherapy alone. We know that this is also associated with high rates of conversion, with promising long-term survival, and probably more importantly, the potential for cure. And as I've shown you, adjuvant therapy is associated with better survival than adjuvant modern chemotherapy alone, which really, it's adjuvant modern chemotherapy alone has not been proven to do anything in the adjuvant setting. Next slide. So obviously, you could look at all these data and propose all kinds of trials. The adjuvant setting is ripe because we don't have an effective adjuvant therapy after liver resection. There is a trial going on in the Netherlands. It's an old-fashioned trial because the Dutch adhere to data. Their standard of care in the Netherlands is surgery alone because they interpret correctly the trials that show no benefit to adjuvant FOLFOX. They are comparing surgery alone to FUDR alone, which is going to be a very interesting trial, and they're actively accruing. We helped them get this trial up and going, and it's been very successful technically and from an accrual point of view. Now, the standard of care in the US is perioperative FOLFOX. That would have to be the comparator, but it's a perfect trial. I think in the first line, this is not something that's ripe for study because we have pretty effective first line therapies. I don't think would be a big appetite there. But in the second line or perhaps more refractory setting, which Mike and I are actually working to develop with our consortium, I think there's really potential with the high response rates and potential for conversion to complete resection. Lots of issues in trial design, which we don't have time for. Most of us would not do a trial without crossover. It would lack equipoise. Certainly in our hands, it would lack equipoise. There's lots of stratification to talk about. And there's building experience. There are a number of programs building, but as I showed you earlier, there are technical issues with this, and you need to build an experience before you probably can start accruing and really participating in a trial where efficacy is to be evaluated. Next slide. So we alluded to this earlier. We now have a consortium of nearly 40 centers in various phases of development of a trial, from people who are just getting off the ground to obviously places like us who've been doing this for 30 or 40 years. But WashU has been doing this for probably the last 15 years. Duke has really ramped up very quickly. UT Southwestern actually has been doing this for a good 10 years. And all these other centers are really now building, and we have now had regular calls. We're building tumor boards for case discussions, and we're building potential for trials. We're actually planning a second line type trial. And to say that we're not interested in the cooperative groups being involved with these concepts would be an understatement, of course. We're obviously looking for funding. And I'll end there, and hopefully I've stuck to my 20 minutes and take any questions.
Thank you, Mike. That was a fantastic overview of the state of the science. I don't see any questions right now, but I'll start the questions with three inquiries from your end. The first is, when a center wants to build a program like this, one of the issues that is ongoing, as you know, many may not know, is availability of the pumps. Can you comment on how easy it is to get these pumps and how one goes about even starting a program if they're interested? Two,
sorry.
Yeah. Two, you alluded to in your last slide is the learning curve. And, you said you wanted to people should build an experience. What does that experience look like? not just from the surgical standpoint, but really from the medical oncology standpoint and the ancillary support like nuclear medicine and nursing and things like that. And lastly, one of the things that we when you discuss this on the national scene is when we talk about it, people always say the same thing over and over. Is like, is it better than systemic FOLFOXIRI? You know, in terms of response, many of the studies you quoted us didn't really include response rates associated with FOLFOXIRI. Is it better than FOLFOXIRI? Can it be combined with FOLFOXIRI? Can you comment on those three things?
Absolutely. So there's a long story with the pumps. For many years, we used what was known as a Codman pump. It worked extremely well. It was very reliable. And then J&J just stopped making it. And it was, in the New York Times, a big story because it was a big deal for us. Very quickly, Medtronic stepped in and helped us. We had to get very creative with splicing catheters together to make it work. I'll shorten the story, but there have been some technical problems, literally technical problems with catheters and things like that. There is a group called Intera who is basically rebuilding the old Codman pump. They are actually being FDA reviewed this week. And I think once that's up and running, which hopefully will be soon, that pump will simplify the use of it. And so that will be one catheter, one pump. And I think it's hard to know the timing, but hopefully it's months that is available and up and running. In the meanwhile, the centers developing there are working with the Medtronic pump and with us to support them. The learning curve, I think from a surgical point of view, we saw complications start to diminish after 25 cases. I don't know that 25 is a magic number, but I think it's in the tens and not in the hundreds, I guess is how I estimate the learning curve. Now, medical oncology is unstudied. I don't know the right learning curve, but I think there has to be a real commitment to maybe come to a center that does a lot of it like us and literally spend time in our clinics. Our medical oncologists who work in sort of related hospitals will come and spend weeks with Nancy Kemeny or Andrea Sursic and do it with them. I also think the learning curve is in the tens and not the hundreds for them. I think there are probably some nuances and subtleties that gets better in the hundreds, but I think the huge learning curve is early on in the tens. The response rate, it's never been compared head to head with FOLFOXIRI. I mean, you have response rates 70 to 80% with FOLFOXIRI. In the first line setting, pump chemotherapy response rates are nearly 100%. It's sort of, I guess I would say 90% to be fair. So it's very similar. Whether the toxicity and conversion to resection are the same, whether there be an overall survival benefit, that's kind of why I don't think the first line setting is the best place to look at this. It's in patients who get some sort of therapy, have had their response, remain unresectable, and after 3 or 4 months, you're not going to get much more of a volumetric response. Those are the patients who I think really are ripe for study.
Question from David Horowitz. The rationale for hepatic artery infusion is similar to that for Y90 radioembolization. Can you comment on your approach to high versus Y90?
Oh, yeah. Well, the rationale is the same, although they're very different. I mean, Y90 is basically a localized intraarterial delivery of radiation, radiation emitting small particles. This is basically high dose chemotherapy. It's what the NIH did when they did, isolation of the liver physically, but it's done biochemically with FUDR. So they're a little different. And the major difference is Y90, and I'll say this in the typical manner that I do, doesn't work. It's not like it hasn't been studied. It's been studied in the second line setting. It simply does not work. And it actually has probably more long-term side effects that I think are extremely underreported in terms of long-term portal hypertension and liver dysfunction. So I don't, you have a one thing that has all this promising data behind it, has single-arm trials, randomized trials, some of which are extremely promising, versus a number of completely negative trials for Y90. So I think the rationale of controlling liver disease is one thing, but the data behind it are not even comparable in my view.
That's great. We have Michael Litzki from Duke, who really has put together this consortium. And I know we're already behind time here, but I think it's worthwhile for Michael to just make a quick comment about the consortium and studies that are currently being planned. Maybe 30 seconds, Michael.
Sure. Thank you, Sai, for including me today. As you can see from this slide, Dr. D'Angelica and I and a number of other institutions now totaling 40 centers, mostly in the United States, but also worldwide, have now come together to design and implement modern randomized pump-focused trials. Before this time, it hasn't been possible to do such, but now that there's so much enthusiasm and excitement, we now have the multi-center experience to really answer the questions and prove what those at Memorial have been doing for decades.
Michael, if someone wants to join this consortium, can you just type in the chat box your email so they can contact you?
Happy to. Feel free to reach out to me and we'll add you to the list. We have regular meetings about every 4 to 6 weeks.
Thank you very much. So let's thank you very much, Mike, both Mikes, for an excellent talk. Really thought-provoking, and I certainly think that this is making a comeback, and I look forward to working with you and from the cooperative group standpoint, designing clinical studies to really prove the efficacy. Our next speaker is our vice chair for the surgical committee, Flavio Rocca, who's a division chief of surgical oncology at Oregon Health Sciences, who will be speaking to us and giving an update from the ECOG study comparing the clinical impact of pancreatic cyst surveillance programs.
Can you guys hear me?
Yes.
Great. Thank you, Sai, for that introduction. So I just want to go through this trial. It's not a new trial. I think most of the folks here on the call have heard it, but I do want to give you some important updates and again, encourage you to either open the trial if you have it open or don't have it open, or encourage more accrual. So just to give a quick, can you advance it, please? I thought I had control for a second. Okay, not gonna spend too much time on the rationale, but I think we all know that, cystic neoplasms are rising in incidence, mainly because we're getting more CT scans and MRIs for unrelated reasons. I think the surgeons on this call are certainly going to be familiar with the Fukuoka or Sendai guidelines were recently updated. It was the third update in 2017. And then the gastroenterologists have come up with the AGA guidelines, which is a little more systematic review based as opposed to consensus or opinion based. There are probably now about 10 or 15 more of these, including the European guidelines and so forth. But these are probably the ones that are two of them ones that are probably most often used. And to be honest, they're not that different in the sense of what they use to surveil. So we have CT, we have MRI, we have EUS, plus or minus FNA, and these are all, expensive modalities, can be imprecise. And obviously, if we had a prospective validated surveillance strategy, it would have a large impact on both primary care, GI, radiology, and surgery. So the trial rationale really is to figure out what the optimal surveillance strategy is. And of course, taking into account the social burdens of cost, finances, mental stress, and so forth. But number one, but most importantly, no patient or physician really wants to miss a high-risk lesion that's been surveyed, but also don't want to expose patients to unnecessary surgery or interventions. Next slide. So the schema is pretty straightforward, and I just want to kind of give you the important points. Is that these are asymptomatic patients. So these are not the ones that typically get referred to surgeons. These are not the post-pancreatitis, the main duct IPMNs. These patients are truly incidentally found cysts. They're within an age range that is a potential candidate for surgery. So not too young, because those patients may want to elect to go to surgery for the fear of having surveillance for their whole life, and also not too old so that they're actually candidates for surgery. We picked a target size cyst of 1 centimeter because the ones that are below 1 centimeter are likely never going to be a problem. And so it also helps us with imaging to have at least 1 centimeter for view. The accrual is quite aggressive. So it's 4,600 patients, and that's due to the power calculation for the endpoints. And it's a 2-year enrollment period with patients being followed up to 5 years. And we're trying to get funding to extend that beyond, as we know that surveillance can take longer than that. And so the randomization is straightforward. It's just either low intensity or high intensity. And the reason we chose those names, that we didn't want to, again, randomize to Fukuoka versus AGA. So we don't want to have that label. So it's really, I think the label is actually fair in the sense of what it entails. Next slide. And so here are the differences between low intensity and high intensity. And again, they're loosely based on the AGA and the Fukuoka guidelines. So really it's all based on CT or MRI. And then it's really the interval of repeat studies. So you'll see in the low intensity arm, it's really just every once a year. Then if there's no abnormalities, going to 2 years. And then to be honest, in the AGA guidelines, they actually would follow stop surveillance at that point. But we wanted to kind of keep these patients enrolled in the study. And so we added the extra surveillance step in the low intensity. In the high intensity follows the Fukuoka guidelines pretty closely. So it depends, the strategy depends on the cyst size. If it's either less than 2 centimeters, between 2 and 3 or greater than 3, and alternates with EUS and MRI. Next slide. So here's the eligibility that we just talked about. So it's that age range. And the initial, what part of the issues that we'll go over as far as accrual is that the initial criteria, patients needed to have a CT or MRI within 3 months of registration. We've now extended that just because that was becoming a barrier to accrual. And the important exclusion criteria include pancreatitis, obviously any pancreatic cyst or malignancy that or resection that's been already dealt with or surveyed, and things that are obviously going to be a pseudocyst or a serous cyst diagnostic on imaging. Certainly patients with a history of pancreatic cancer, first relatives, we did not want to confound the picture, and also not patients that are already being followed. Next slide. So here are the protocol amendments that have been changed. And again, this is not meant to be the all-inclusive detail. We do want you to reach out if there's any questions. But as we talked about, the baseline timeframe is going to be expanded from 3 months to 6 months. So again, if patients have had a CT scan within 6 months with that incidental cyst, they'll be candidates. They can have the cyst previously identified, just not under surveillance. And multiple patients with multiple cysts are permitted as long as there's one cyst that fits the criteria, and that's the one that the target cyst that's being surveyed. So these amendments are being sent through, so they should be approved actually next month. But please feel free to reach out to the ECOG staff or me or anyone else if those questions are not clear. Next slide. To give you a sense, so this is the accrual status as of a couple weeks ago. So the study was unfortunately activated January 16, 2020, right about, I think, a week before the first case of COVID in the US was diagnosed. And so certainly as the country went into lockdown, it's been a little bit of an issue, certainly even for cancer studies. So this is a cancer surveillance study. So we've had 43 patients accrued to date, which is, sounds disappointing. We do have 193 sites that are open, but always looking for more. And you can see the breakdown there as far as what types of sites were open. But again, we're hoping with the protocol modifications and as we emerge out of this pandemic, that patients will continue their screening activities and hope to get this trial enrolled. Next slide. So any questions? David Weinberg is actually the PI. He's a gastroenterologist, and he's actually the chief of medicine at Fox Chase. He's certainly always available for discussions, but certainly feel free to reach out anytime. And I'm happy to take any questions.
Flavia, for the sake of time, maybe just have people email you for questions, and if you don't mind introducing the next speaker.
That would be great. Okay, can we have the next slide up? All right, great. So it's my pleasure now to introduce Virginia Sun, who is an associate professor of population sciences in the Department of Surgery at the City of Hope in California. And she actually has a very interesting trial looking at altering and managing symptoms and intervention for bowel dysfunction and rectal cancer survivors. And Virginia will introduce the trial. Thank you.
Thank you very much for the opportunity to be here. So I am here to give brief updates for two concepts. The first one is S1820. It is a preliminary efficacy study testing AIMS-RC, altering intake, managing symptoms intervention for bowel dysfunction and rectal cancer survivors. This is a randomized pilot trial. I do want to acknowledge the many years of funding support through the Hope Foundation for Cancer Research. This concept started as a concept that was developed in the Young Investigators Training course. We did receive seed funds to do a small feasibility pilot, and that led to the R21 that supports this current trial, as well as the clinical trial support funds from the Hope Foundation for Cancer Research. Next slide. I want to acknowledge our team. This team meets every week since we started activation, and so I appreciate all of their support so we can keep the trial going. I do want to acknowledge in particular our GI committee champions, Dr. Mazen Al-Kaspouls, who's a surgical oncologist, who is our surgical oncology champion, and we have medical oncology champion, Dr. Stacy Cohen as well. Next slide. This is our study schema. We are enrolling rectal cancer survivors in the gray box to your left. Our total target sample size is 94, 47 per arm. We are focusing on a truly post-treatment population. So we are enrolling participants between 6 to 24 months post-treatment completion. We are including survivors with both an ostomy or an anastomosis. This is based on some of our preliminary work. So we are testing this intervention in both of these populations. For the anastomosis population, they will need a score of a low anterior resection syndrome score of 21 to 42, which indicates minor to major symptoms. We are focusing on English-speaking patients in 18 years and older, which is the adult definition. Patients will complete surveys. They will complete a 14 to 21-day run-in period, which is a common design and behavioral interventions to really be able to improve adherence. So we're going to be collecting some dietary recall data, 3-day food and symptom diary from them during this time point. We do have definitions in terms of completion of the run-in period. So once they complete the run-in period, they will then be randomized to the intervention arm or the attention control arm. So AIMS-RC is a telephone coaching call, 10 telephone coaching call delivered over a 4-month period. It lasts about 20 to 40 minutes for each of the sessions. We really incorporate classic behavior change theories through goal setting, helping them with identifying and overcoming challenges. We use a food and symptom diary to personalize the approach and coach patients on understanding the relationship between the food their food that they eat and their bowel symptoms. And then we work with them to appropriately adjust their diet as needed. We use motivational interviewing and problem-solving approaches. They will receive a resource manual, and in between the 10 telephone calls, we are providing personalized text and email messaging to support their continued diet modification. The attention control arm is our control design. We chose 10 healthy living education topics that are listed here in the yellow box. These are all delivered by telephone calls as well over a 4-month period. They will also get a resource manual and will receive automated standard text email messages in between the phone calls, focusing on the 10 topics. The intervention is all centrally administered by telephone by trained health coaches at the University of Arizona under the direction of my co-chair, Dr. Cindy Thompson. We will follow the participants at 18 and 26 week with patient-reported outcomes. And our primary endpoint is bowel function, is measured by the Memorial Sloan Kettering Cancer Center Bowel Function Index. We have a whole host of secondary outcomes, quality of life. We're looking at the LARS score, self-efficacy, motivation, a panel of sort of behavior change constructs, diet quality through the 24-hour dietary recall, and still looking at feasibility, adherence, retention, and acceptability. Next slide, please. So we are very grateful to all the sites for participating in this trial. We were activated on December 9th, 2019. We were able to, again, grateful to continue with this trial through the pandemic because everything was done by telephone and we had some flexibility in terms of data collection. So we are about 53% accrued, 49 out of 94 randomized as of early this month. I think this number may have changed already. Probably we hit 50 in the last week or so. And as you can see, this is a accrual randomization graph that we sent to all the sites, site investigators and site coordinators to give an update. We've been pretty steady across accrual across on a monthly basis. And we do have a publication that was just accepted, which is our protocol paper. Next slide, please. And I just have a few more slides to give a quick update on S2016. So moving from rectal cancer to pancreatic cancer, I am here to present this on behalf of Dr. Vincent Chung, one of our medical oncologists at City of Hope, who's the study chair for this. concept, and I am a co-chair. So this is a randomized phase 3 trial of a primary palliative care intervention to improve quality of life for metastatic pancreatic cancer patients. Next slide. This is our proposed study schema. We are focusing on metastatic pancreatic adenocarcinoma populations. We will enroll participants within 8 weeks of initial diagnosis, performance status of 0 to 2. Again, focusing on an English-speaking population for this initial trial, and of course, focusing on adults. We are going to be enrolling family caregivers as much as we can. Patients will be able to participate if they don't have an identified family caregiver. And the family caregiver is defined as someone that's identified by the patient, who knows the patient well and is involved in the patient's medical care. We randomize them to 2 arms. So we're using a similar approach of centrally administered intervention by telephone. This time around, this intervention is delivered by advanced practice nurse practitioners that are located at City of Hope. The intervention is a primary palliative care intervention, and we define primary palliative care as care provided by clinicians who are not board-certified palliative care specialists. And this is delivered by 12 telephone sessions over a 3-month period, 6 for patients, 6 sessions for family caregivers. They will get a manual as well. And we will create a palliative care plan that's organized in a quality of life domain, physical, emotional, social, spiritual well-being, and provide that to the site and the site's clinical team. And the attention control arm will be receiving just standard quality of life education, 12 telephone sessions as well. We are using the NCI Coping with Advanced Cancer booklet as the material for this arm. We will do 3-month follow-up and 6-month follow-up. But the primary objective is quality of life is measured by the FACT-HEP at 3 months, comparing the intervention control arms. And we will also be collecting data from the family caregivers as well, such as psychological distress, caregiver burden, and their quality of life. Next slide. This is my final slide, I think. Just update. So this concept was approved initially on May 4th, 2020. As with all cancer control NCORP trials, most of the time we do need funding. So last June, we did submit an R01. We were scored, but didn't quite make the pay line. We were close, but not quite there. And so we just recently submitted the R01, and this will be reviewed later on this year. So we'll be crossing our fingers, lighting lots of candles to make sure that we have a favorable result for the grant application. So that's all I have, and happy to take any questions. Thank you.
Any questions for Dr. Sun? All right. Virginia, thank you for the update. Again, for the sake of time, we'll try to catch up here. We're going to just move along right along. If you have any questions, please email Dr. Sun directly. If you don't have these studies open, I would highly recommend opening them. These are studies that patients very much want to participate on and are very invested when they're enrolled, for sure. And I think all cancer centers are looking for expanding their population science portfolio, and these certainly qualify. So I would recommend, if you don't have them open, to open them in your cancer center portfolio. And Dr. Roca will introduce the next speaker.
Okay. So the next topic is going to be introduced by Dr. Patel, Samir Patel from the University of Cincinnati. And it's a colorectal high-PEC concept for high-grade appendiceal carcinoma. And this is obviously, as you can see, a multi-institutional, multi-investigator effort, including Dr. Deneen, Dr. Raghav, Dr. Senthil, Dr. Kelly, and Dr. Deneve. Samir?
Thank you, Flavio and Swag, for the opportunity to present and provide an update. Now we can go to the next slide. So we've gone through this concept several times, but just as a brief background, I think as everyone can appreciate, appendiceal cancer is a rare but also a very heterogeneous disease. And for the fraction of patients that present with peritoneal-only carcinomatosis, cytoreductive surgery with high-PEC provides a treatment opportunity and actually a curative option for these otherwise incurable patients. Unfortunately, only recently within the US, there's really a lack of any prospective studies that really guide treatment. And even that one study really didn't focus on survival, but rather the primary endpoint of toxicity associated with the intraperitoneal chemotherapy used. And until only recently, and as of last year, The best data that we have are really based on consensus guidelines. And so for appendiceal cancer, you can see there's a broad breadth of treatment opportunities with either use of cytoreductive surgery HIPEC alone, after CRS HIPEC, moving with adjuvant therapy, or utilizing more of a preoperative or a perioperative approach whereby patients receive 3 to 6 months of preoperative therapy, then they undergo CRS HIPEC and then receive additional adjuvant therapy. For patients with high-grade appendiceal cancer, many are treated in the setting of either use of perioperative or a neoadjuvant approach. We can go to the next slide. And a lot of the parallels are really drawn with what we know about peritoneal carcinomatosis in patients with colorectal cancer. Unfortunately, the PRODIGE 7 study, which was just recently published, whereby patients with colorectal cancer with peritoneal carcinomatosis were randomized to receive either a course of preoperative systemic therapy and then ultimately randomized to CRS with or without HIPEC, really showed that there was no difference in their primary endpoint of overall survival, which was 41 months in both arms. Now, these data were met with a lot of criticism, in large part because of the techniques of randomization, use of the intraperitoneal chemotherapy, which was only oxaliplatin for a duration of 30 minutes, and several other methodologic issues. And so the ECOG group is working on a similar kind of US version of the trial, or the CATCH trial, whereby the same patient population, after the course of 36 months of preoperative therapy, would then be randomized to CRS or CRS with HIPEC. The key difference being that the intraperitoneal chemo regimen used will be mitomycin delivered at 120 minutes duration, with the primary outcome or endpoint being progression-free survival, and the secondary being overall peritoneal recurrence-free. The issue may still very well be that despite this, and with an estimated sample size of over 500 patients, the results may ultimately be the same, with this still being a negative study. We can go to the next slide. And so the only existing prospective study was this multi-institutional study with Wake Forest, MD Anderson, and UPMC, where they examined patients with appendiceal cancer, mucinous and non-mucinous, were randomized to either two intraperitoneal chemo regimens, and that was either mitomycin or oxaliplatin. The primary outcome was examining the toxicity associated with each of the IP regimens, and there were differences, but some of the key findings that they found was that when you examine these patients with either low-grade or high-grade appendiceal cancer with peritoneal carcinomatosis, you do see that there's a substantial difference in their prognosis and their overall survival, with high-grade tumors behaving very, very different biologically compared to those with low-grade. So the studies showed that these groups are truly heterogeneous and that we can't really be using low-grade and high-grade in similar studies. And the other final issue is that high-grade has not really been defined very clearly, as many of the retrospective single institution studies' definition of high-grade differs. And it really wasn't until the SWOG guidelines in 2016 that people started adopting a more universal approach. And so we really do need a study that specifically is targeted or geared towards high-grade appendiceal cancer. Next slide. And so our primary objective of this trial was to really establish the role of multimodal treatment using systemic therapy with CRS HIPEC for patients with high-grade appendiceal cancer. Next slide. And so for our schema, we defined high-grade specifically as patients with moderately and poorly differentiated adenocarcinomas, and they can have with or without signet ring cells as defined by SWOG. And essentially these patients would then go and undergo laparoscopy for PCI assessment, as we know that radiography is notoriously inaccurate in truly identifying true PCI score. For those patients with a PCI less than 20, they would then go on to receive 3 months of FOLFOX or FOLFIRI. Those patients that had stable disease or a partial response based on imaging will then have the option of going on to receive an additional 3 months of systemic therapy. And if those patients still had stable disease or a partial response, they then go on to CRS HIPEC. For those patients that after 3 months have evidence or during any point have progression, will then have a change in their systemic regimen, and then if they have stability of disease, could go on to CRS HIPEC. Our primary endpoint was a clinical endpoint of 2-year recurrence-free survival. Our secondary endpoints being listed are really completeness of cytoreduction, overall survival, pathologic as well as imaging response, peritoneal disease-free survival, and then symptom-free survival. We also plan to do quality of life surveys with use of MADAS here, 5Q, 5EL, and also have a correlative component where we would bank serum, but also have our primary analysis of really examining exosomal microRNA, which I'll kind of go into. We estimated needing a sample size of about 40 patients, and we intend to use central pathologic as well as radiographic evaluation to provide a little bit more homogeneity in this population. Next slide. Based on existing data from one of the HIPEC collaboratives, we know that within kind of this 12-volume collaborative, there's roughly about 20 to 30 patients that we see per year. About a third of these patients will have a PCI of more than 20. And so we expect to accrue or need to have at least 14 high-volume centers that can accrue at least 2 patients per center per year. And using our historic control of 40% 2-year recurrence-free survival, we expect that in this study population, we'll be able to achieve a 65% 2-year recurrence-free survival, and needing a sample size of about 30. And with our percent drop-off, we estimated needing to at least enroll 40 patients. Next slide. And so touching base a little bit on the correlative component, this is largely from the work of Maggie Senthil, who's now at UC Irvine. So our primary examination was to look at the exosomal component within the serum and examine the microRNA. And much of our preliminary data shows that using microsomal RNA, she's been able to differentiate patients that have peritoneal carcinomatosis as opposed to those patients that have visceral metastases and those without having either and just have the primary in place. We know that ctDNA is notoriously insensitive for examining peritoneal carcinomatosis with sensitivity rate of about 30%, whereas it's been 80 to 90% in examining exosomal microRNA. And so not only are we examining the prognostic value of it, but also the feasibility of really sample collection and analysis, particularly because we'll be needing so many centers that'll be participating. And so thus far we've presented and made modifications to our capsule to the colorectal committee, and they've approved the capsule, and hopefully after tomorrow we'll be able to move to statistics. But we can go to the next slide, and I'd be happy to take any questions.
Any questions from the audience? Samir, can you update us on, I have 3 questions and comments. Can you update us on where the study is currently in development? Can you comment a little bit on why you excluded PCI greater than 20? And can you talk to us about the radiology review? Will that be real time? Will that be retrospective? And how do you think that will impact dropout rates?
Yeah. So the first point right now, as I said, is so far the capsule has been approved. And so I believe that the next step would be to move forward with statistics review with Catherine. And I think if she agrees, then we can kind of move forward and begin the process of opening the trial. But I believe there'll be a final approval tomorrow during the GI working group meeting. As far as the second point, we excluded patients with PCI greater than 20 because we know that completeness of cytoreduction, which is not achievable oftentimes in patients with such a high PCI, particularly in the high-grade group, the prognosis is very, very different, and just increasing the heterogeneity of the study population was something we didn't necessarily want to do, which was the reason why we used a PCI of 20. Whether using a PCI of 20 versus 25 is somewhat of an arbitrary cutoff, but based on multi-center studies and kind of high-volume centers experiences, we chose 20 as that seemed to be kind of the most cited and the one that was kind of used by many centers. And then finally, as far as the radiographical review, the intent was to use this initially as real-time, kind of being optimists, but I think the reality may be that as we kind of move forward in the capsule, that was one of the areas of debate. It wasn't intended to be a kind of one of the key components, but we thought about doing it kind of in a after-the-fact fashion, but that's one of the things that I think is still going to be discussed. And that would drastically change, as you said, with the higher dropout rate, particularly if we do that. I think we really will need every center and every patient that we can get, because although this is a relatively small sample size, it will literally require almost every patient out there to be able to accrue an estimated time period.
Flavio, any comments?
No, I think this is the question with these types of studies, is that we have to find the appropriate population. The initial HIPEC studies and the Alliance just never accrued because there was such a significant bias towards the therapy. And so I think this is a well-designed, feasibility study really to get that information now that we have, again, much like the pump, a renewed enthusiasm here in studying this treatment modality.
Great. You want to introduce the next speaker?
Yeah, my pleasure. Next slide.
Thank you.
Great. So our next speaker is Dr. Michael Wagner, who is the medical oncologist from the University of Washington, and he's been part of the SWOG Early Therapeutics and Rare Disease Committee, and now our new sarcoma committee as well. And he's going to talk to us about a very interesting concept we've been developing in that committee about neoadjuvant nivolumab and paclitaxel, followed by definitive local control for patients with angiosarcoma. Mike, take it away.
All right, thank you, Flavio, and everyone else for the opportunity to present here. So I think I'll actually be probably more brief than some of the other presenters, and this is, I guess, a little bit earlier on in development. But this is a concept that we've, as Flavio just mentioned, been developing with the Early Therapeutics and Rare Disease Committee within the sarcoma working group. As you go to the next slide. So these are just my disclosures. Next slide. So just a little bit about angiosarcoma, because this is a group of surgeons. So angiosarcoma is a very rare cancer. There's only about 500 cases diagnosed in the entire country in the US per year. They account for a single-digit percentage of all soft tissue sarcomas, which collectively are pretty rare. About 15% of angiosarcomas present, or patients with angiosarcoma present with metastasis, which means about 85% present, at least initially, with localized disease. And they can come up in really any part of the body. It's a cancer of endothelial cells. So really anywhere that there's blood vessels, one can develop an angiosarcoma. And they come in general, two flavors, at least historically, either primary or secondary, where primary angiosarcomas are ones that just arise, and secondary angiosarcomas are ones that come up in settings where a patient had previously had radiation or had chronic lymphedema. And you can see from the table just the general distribution of the primary sites of angiosarcoma. So they're pretty commonly found in the head and neck and breast, and especially in the skin. Next slide. We're now starting to have a better understanding of the molecular characterization of angiosarcomas. And even though they're incredibly rare, what we're learning is that it's an actually very heterogeneous group of tumors where we're seeing certain characteristics and groupings depending on the primary site, and then also molecular signatures. So in particular, there's a subset of angiosarcomas that have a high tumor mutation burden, and they generally tend to have a DNA mutation pattern consistent with UV exposure. Those tend to be tumors of the skin in the scalp or face, which sort of makes sense. And then there are also some patients with a high TMB who have radiation-associated tumors. Next slide. So because of that data, we were able to add a cohort onto the DART study, which is another SWOG study run through the Early Therapeutics and Rare Cancers Committee, which is a study of ipilimumab and nivolumab for a whole host of rare cancers. So there's over 50 cohorts, and 16 patients enrolled on the angiosarcoma cohort. And of those 16, 4 of them had a confirmed radiographic response. When we further analyzed which of the patients were the ones who had a response, there seemed to be a predilection for patients with cutaneous disease, and especially with cutaneous disease of the scalp or face, which is as we would have expected based on the molecular data. One thing that was particularly interesting, though, is that there were 2 patients. So one had a radiation-associated tumor of the breast, and we don't have a TMB assessment for that particular patient, also responded. And then a 5th patient who had a primary tumor of the liver, who didn't have a confirmed response, but did have a tumor reduction for a period of time. And that's not something that we would have necessarily expected. So it's at least possible that immunotherapy might be more broadly beneficial in angiosarcoma patients as a whole, but it does seem like there's a particular subset that is more likely to respond. And all of these patients had metastatic disease or unresectable, and for the most part had been heavily pretreated. And next slide. So what do we do for localized disease? So still, surgery is a key component of, sorry, I just saw my dog jump up, of treating localized angiosarcoma. But however, because of the infiltrative growth pattern of these tumors, it often requires very disfiguring surgeries. As you can imagine, an angiosarcoma on the scalp requires a very wide resection, and there's just not much tissue left over when you do a wide resection on the scalp. We would generally include radiation, with the exception of radiation-associated tumors, and for the most part, although it's controversial, will include chemotherapy. At least my preference and the preference of a lot of medical oncologists is in the neoadjuvant setting. Next slide. So the European sarcoma centers collated their experience treating angiosarcomas with definitive local therapy, and most of these patients also got chemotherapy. The chemotherapy choice differed just because this was not a study and it was a retrospective analysis, but the most common treatment that patients got was Taxol. And if you look at the disease-free survival, either from diagnosis or from surgery or local therapy, the median PFS was about 1 year or so. So about also half of patients were disease-free at the 1 year time point. Next slide. Oop, go back one. Okay, so next slide. I think something jumped ahead there. So the study that I'm proposing is a study of neoadjuvant paclitaxel with or without nivolumab, and this is based on that retrospective data, and then also just our general standard preference of care based largely on consensus and case series, where we know that Taxol is active in angiosarcoma. The response rate's actually generally greater than 50%, depending on what study you're looking at. And immunotherapy we have great interest in because of the DART data and also anecdotal data of other patients responding. There are some other studies for patients in metastatic disease, and there's still a great need for improved treatments in patients with local regional angiosarcoma. So what we're proposing is for patients with localized either resectable or unresectable angiosarcoma to treat in a randomized fashion with either just neoadjuvant Taxol for 12 weeks or neoadjuvant Taxol with nivolumab, followed by definitive local therapy, which can either be surgery, radiation, or the combination of surgery and radiation, depending on the institutional preference. Next slide. And then after local therapy, for the group that gets Taxol, will initiate surveillance, just as per standard of care. And then the other group will have adjuvant nivolumab to complete 1 year of nivolumab, consistent with some other similar studies. This study, at least as it's proposed now, would allow for crossover to try and sort of increase the likelihood of accrual. Next slide. The statistics of this, so it's a 1-to-1 randomization with a primary endpoint of progression-free survival. Because this is a very rare cancer, and this is essentially just a phase 2 randomized study, the alpha is 0.15 with a power of 85%. The assumptions on which these statistics were based were a 1 year progression-free survival of 50% in the Taxol only group, with an improvement by 20% to 70% progression-free survival in the Taxol plus nivolumab group. This would require 50 patients per group, so 100 patients total. And if we sort of extrapolate from the DART enrollment, we think we'll be able to enroll about 3 to 4 patients per month, and accrual for the entire study would take about 2.5 years. Next slide. Secondary endpoints would include response rate and overall survival. And I think importantly, we're also going to try and include some exploratory endpoints, especially correlative markers to look at pathologic complete response. And then also, because of the data that we presented, or that I presented just a few slides ago, we'll also look at subgroup analyses by the primary site of the tumor, and also collect samples for tumor mutation analysis and TMB. Next slide. So that's, I guess, the quick version of that study. I'm happy to take any questions.
That's great. Thank you, Mike. Any questions?
No questions. I just want to kind of congratulate Mike for kind of keeping this effort going. It's kind of it's a tough tumor in the sense that it's rare. So I think the big thing will be getting, plenty of centers to accrue. So please, be on the lookout for this.
I have a couple questions. One is, will this be an intragroup study or just limited to SWOG?
So hopefully it will be spread across other groups. So there's actually a similar study through Alliance, which is actually for patients with metastatic disease, which is a very similar study. So it's randomizing patients to Taxol versus Taxol plus nivolumab. And really, because of the existence of that study, we wanted to focus on the neoadjuvant setting. But hopefully we'll be able to use those same mechanisms that study is using to increase enrollment.
And does enrollment in the study require a pre-op biopsy for TMB status or no?
So I don't think we'll require a study-specific biopsy, but we will collect archival samples.
And
So
do you know if therapy changes? Like, so if you enroll people on a study, I mean, I don't know the answer to this, but will the molecular profiling change after it's been treated?
So I guess we don't know the answer specifically, but I suppose it's possible. So one thing that I don't think would necessarily change would be the TMB. Certainly there are patients, just as an example, so people who have been treated with pazopanib, so a VEGF inhibitor, resistance mutations can develop. So sort of in that sense, that molecular alteration would be probably specifically in response to the treatment. But I guess just like with any other cancers, these tumors evolve, and there is some time dependence on the molecular findings.
Great. Any other questions? All right, thank you very much, Flavio.
Thank you.
Yep. Next slide. So it's my pleasure to introduce Dr. Luisa Suarez from the Huntsman Cancer Institute at the University of Utah. And she's going to be giving us an update on S2104, which is a randomized phase 2 trial of postoperative adjuvant CAP-10 versus observation in high-risk pancreatic NETs, of which our esteemed chair is also a co-investigator. Luisa?
Thank you so much, Dr. Roca and Dr. Ahmed, for the opportunity to give updates on the S2104. As you all know, this is a trial that is designed to answer the question whether or not cytotoxic chemotherapy will impact the recurrence-free survival in patients that have pancreatic neuroendocrine tumors that have been resected and are high risk for recurrence. This is the official study group as it stands right now. I think there's going to be some touches on that. I also want to acknowledge the NET subcommittee that is led by Dr. Strasberg and Dr. Desari. We have multiple conversations about this trial, and I need to formally acknowledge Dr. Samir Patel, who has helped in developing this protocol, has also helped me with the initial draft of the proposal, and hopefully will be officially joining the study team soon. We already have identified 2 study champions, and we're pending assignment of ECOG acronym study champion from the study. Next slide, please. These are just more disclosures. Next slide. You all have seen probably, if you joined these calls before, these meetings, the rationale for doing this study. We know that pancreatic neuroendocrine tumors tend to recur faster than small bowel tumors. As you can see here in this database that was published a few years ago by the Canadian group. There are several retrospective studies that have been shown that half of the pancreatic neuroendocrine tumors, if they were to recur, they would recur between 24 to 36 months. And most of the studies also pointed out that tumor size, particularly larger tumors, tumors more than 4 centimeters, for example, positive lymph nodes, a higher grade with a higher Ki-67, and patients that have upfront metastatic disease that has been resected are the ones that will most likely suffer recurrence within these 3 years. Next slide. This is just a summary of some of the studies that have been published. I have showed this data before, and again, continues the theme that if tumors were to recur, there's the median time of recurrence will be within 3 years or so. Next slide. Thanks to the work from the U.S. neuroendocrine tumor study group, we have again confirmed that there's a high likelihood that if the tumors were to recur, they will do it within the first 36 months. And here you can see that the overall median recurrence-free survival of these patients is about 20 months. Next slide. I was also very thankful when this updated publication came up, because when I initially discussed this concept several years ago, probably about 3 years ago, one of the arguments that has been brought to my attention is that even if these tumors were to recur, and that wasn't necessarily affecting overall survival of these patients. And here, this 1,000 patients collections do show that there's a likelihood that indeed overall survival of the patients will be impacted if they were to recur. Not to mention that you have to then start treatment in these patients for a much longer period of time, right? Rather than just doing adjuvant treatment for a short period of time up front, then if they recur, and that opens up for a much longer period of treatment. We also now see that there is impact in survival. So there's a really good data that support with moving forward with this study. Next slide, please. Next slide. A little bit, one more click. Thank you. One more click. So we don't have any good prospective studies that have been done to address the role of adjuvant treatment in patients. There was this poster that was presented at ENETS a year ago or so that showed that patients that received octreotide, somatostatin analog, in the adjuvant setting for 6 months, perhaps did a little bit better if you click the next slide compared to observation. And you can see the patients that received that, the disease-free survival in 36 months was 93.9%. And if you look at the observation arm, was 81.3%. Again, showing that perhaps there is a role for some sort of treatment. Next slide, in the adjuvant setting. So in terms of how to select the best intervention, if we were to examine the role of any adjuvant treatment, all this target therapy, somatostatin analogs, everolimus, sunitinib, that we can use in the metastatic setting, they're actually cytostatic, they're not cytotoxic. Immunotherapy, there's a lack of evidence for the use in well-differentiated tumors. PRT is extremely toxic. We don't know the long-term toxicity. There's a 3 to 4% risk of AML, MDS with that, and we don't know how much will target actually micrometastasis. And then we have old-fashioned cytotoxic chemotherapy. Thankfully, in the last few years, a study using capecitabine and temozolomide in the metastatic setting was published and show the benefit of the combination of treatment in the metastatic setting. And as in any other solid tumors in GI, we then can extrapolate and try to see the role of the cytotoxic therapy in the adjuvant setting in pancreatic neuroendocrine tumors. Next slide. So based on that, we develop our phase 2 randomized trial of post-op adjuvant CAPE-10 versus observations in patients that high risk for a recurrence from pancreatic neuroendocrine neoplasms. We initially designed a 1-to-1 randomization and 6 months of treatment with that versus observation. This was then sent to the GI steering committee and then CTAP as a second step. And we received the feedback that they would encourage us to do a 2-to-1 randomization. So we have adjusted for that. And they also encourage us to do 4 months of treatment versus 6 if we accept that. So as it stands right now, patients will be randomized in a 2-to-1 fashion for 4 months of chemotherapy versus observation with monthly visits, either via telehealth or in person for the initial 4 months of treatment. And also patients will be followed with CT scans every 6 months for the first 3 years, and then every year annually for the following 2 to 3 years. Our sample size right now is about 150, includes 154 participants, because we need about 141 eligible patients for this study. Next slide. In terms of how do we define high risk for recurrence? This is how we initially designed the study. These patients will be patients with a well-differentiated neuroendocrine tumor with grade 2 or grade 3 tumors. For the grade 2 tumors, they had to have a tumor that is equal or more than 4 centimeters and or positive lymph nodes. And for the grade 3 tumors, they had to have the Ki-67 of less than 55%. Why? Because from some retrospective studies, we know that if Ki-67 is much higher than that, perhaps a platinum chemotherapy would be better than CAPE10. We don't have randomized data to answer the question, but that's just based on the experience from other studies. And patients that had resection or ablation of oligometastatic liver disease up to 5 lesions and had fully resection of the tumors will also be eligible for the study. Patients with germline mutation tumor that exposes them to pancreatic neuroendocrine tumors will be eligible for the study as well. We received last week feedback from CTAP that they would like us to adjust a little bit our eligibility criteria in terms of definition of high-risk patients. So we will be having a slight revision of this eligibility criteria with the goal, again, of capturing the high-risk patients. In terms of other updates, I have been in touch with the Digital Engagement Committee, and we hopefully will be working in launching some educational video for patients to educate them about the importance of participation in this trial. I have reached out to them because this is a rare population, and our control arm is observation. Pancreatic neuroendocrine tumor patients are extremely well educated about their disease, and I strongly believe that if we provide educational materials for them, we will facilitate accrual. Also, we'll probably be developing videos for physicians as well. And we're potentially working in actually assessing the impact of video consenting for these patients. That's something that I'm discussing with the Digital Engagement Committee. Actually, we discussed that yesterday in the meeting, and hopefully we can use our trial as a pilot, a further pilot to how to use online resources to facilitate awareness of the trial, both from patients and physicians in the community, as well as facilitate accrual. And that's what I have. Next slide. I just want to thank everybody, Dr. Rocha, in addition to Dr. Ahmed, who have been super supportive of this study. Dr. Patel has been like a trooper with me, and many other folks that are on this call and through the GI SWOG surgical committee. Thank you. I'll open for questions.
Thank you, Heloisa. Any questions from the audience? Can you comment on what you think the timeline will be if everything goes according to plan in terms of when enrollment will start?
So once we submit, I think our adjustments to CTAP and everything goes smoothly, I think towards the end of the summer, initial of the fall. And I don't know if Catherine's on the call that can comment further on that, but we're working with by fall for sure. And
can you just comment on translational endpoints that?
Thank you so much, Dr. Yeah, so we will be collecting blood in 3 time points after surgery at 6 months at the time of progression. We will also be requesting tissue from the surgical resection, and we are also collecting the NET test, which is a transcriptome profile blood testing to check whether or not we can predict recurrence with that. So in terms of translational work, we plan to work with Dr. Christopher Wugfen, who is now at NYU, and try to validate some of the prior biomarkers that have been used to predict recurrence, and we'll be able to do that, and whether or not the impact of chemotherapy will change that. That's one of the things. But we'll be open if anyone wants to and have any other ideas for translational work. We'll be more than happy to take suggestions and collaborate.
Thank you very much. Flavio?
Yep. Next slide, please. So I think rounding out our agenda today, we have two presentations. One by Dr. David Horowitz from Columbia University, one from Dr. Sepide Golami from UC Davis. And this is referring to what Dr. Kachnik was mentioning earlier about secondary analyses and kind of the potential that we have to actually look at these studies that have already been completed. So the data is there. And obviously this can't happen without the help of Dr. Guthrie and Dr. Duong in the SWOG Statistical Center as well. David or Sepide?
Thank you so
Whoever
much.
wants to go first.
Can you guys hear me okay?
Yes.
Sounds great. Thank you so much again. We really appreciate both Dr. Horowitz and I want to thank everyone, as part of the committee, as well as really Dr. Ahmad and Dr. Roca, as well as the statistical group for their help with getting these really quickly done and submitted for abstracts, as you will see in this presentation. Next slide, please. So I really wanted to give you a background about the secondary analysis that we did for a phase 2 trial that was done in resected patients with extrahepatic cholangiocarcinoma and gallbladder cancer, the SWOG-0809 study. So in summary, this was a patient population including T2 to T4 or patients with N positive or margin positive disease that included extrahepatic gallbladder cancer of 68% of the patient population and gallbladder cancer 32%. These patients received adjuvant chemotherapy for 4 cycles with gemcitabine as well as capecitabine, and then followed by adjuvant chemoradiation of 45 grade to the regional lymph nodes with capecitabine in conjunction. The study really focused on the overall survival and disease-free survival of these patients shown on the right top graph. And specifically, they wanted to compare to historical controls with regards, that's how the statistics were done. So with regards to the statistical controls for patients with R0 and R1 disease, those numbers were 2-year disease-free survival of 55 and 35%. And the statistics were set so that the clinical trial would be significant if the control rate was greater than 65% in the R0 disease and greater than 45% for the R1 disease. So this trial ended up being positive. Next slide, please. However, what they did not really focus on in their analysis was really what was the effects of lymph node status. So with that, we are going to present 2 specific abstracts. So one was on the left side showed we focused on the lymph node status and impact of the overall survival and disease-free survival on these patients. And specifically, when you look back, we found that the meta-analysis certainly showed that there might be some benefit for patients with hilar cholangiocarcinoma that are N positive to have receive adjuvant chemotherapy in addition to radiation therapy. However, we really have not studied this in a clinical trial setting. And so that's why we focused really that specific question using this population from this clinical trial in a secondary analysis. On the right side, you see that the second part of the question on the study really focused on looking at the 2 different types of radiation that these patients received. So one of which was 3 conformal radiation with IMRT versus the 3D conformal. Again, this trial allowed for a variety of doses, which Dr. Horowitz will go over in detail, and different techniques. So we really asked that question, does the treatment modality and the different techniques and what really the specifics these physicians end up using in their analysis, did that actually impact overall disease-free survival as well as some and looking at specifically at some toxicity and other survival curves. Next slide, please. So here's our first abstract that we submitted, and we're excited to say that it's been accepted at ASCO meeting for the summer. Next slide, please. So again, the question was, does nodal status impact the survival in these specific patients who had adjuvant chemoradiation? This is just the basic characteristics on the patients. So we included 69 total patients, 79, sorry, total patients who were included in the study. There are really no significant differences in the characteristics, except for that a higher proportion of females, 71% almost, had N0 disease versus N1 disease in the males. And then specifically, if you also look at the gallbladder versus bile duct cancers, a greater proportion of bile duct cancers ended up having N1 disease as expected. So this was not really a big surprise. Next slide, please. Then we really focused again on overall survival and disease-free survival stratified by nodal status. You can see that the survival difference on the left was not significantly different between N0 and N1 patients. So similarly, the disease-free survival was not significantly different between N0 and N1 disease. Next slide. Looking specifically at the local recurrence and distant metastatic rates, you see that the local recurrence rates were similar in the N0 and N1 disease, but we did notice a significant difference in the patients with N1 disease as opposed to N0 disease, almost doubling the distant recurrence rates. Next slide, please. Here's a table with a univariate analysis looking at various parameters and variables which could impact, again, overall survival and disease-free survival. I think it's important to note that N1 versus N0 disease did not play a significant role with regards to the survival differences, as well as did not like with R0 and R1 versus R0. And specifically, I think what we wanted to really focus on in our analysis, next slide, please, was really how does this compare to historical controls? Because like we said, the first initial analysis of this clinical trial was really set to be positive based on the comparison of receiving adjuvant chemoradiation compared to just patients who received surgery in the past. So we did a very long review of the literature. These are the three papers that we came up with that mostly represented good historical controls that did not receive any sort of adjuvant chemoradiation. And so based on this, next slide, if you can just click, please. One more. Thank you. And so with that, you can see that we then we came up with a mean historical DFS for N1 disease was 13.7 months versus 39.3 months. These are based on those papers. We then defined this into the 2-year disease-free interval so that we can compare that with our specifics in our analysis. And then we did note that there was a significant difference for the patients who had N1 disease. So that comparison was almost doubled if you look, or not nearly doubled, with almost 50% versus like 29% with a p-value of 0.004. Next slide. So I think we've really shown that the combination of adjuvant treatment with chemoradiation followed by following curative resection for extrahepatic cholangiocarcinoma as well as gallbladder cancer provides like favorable outcomes, really regardless of nodal status. I think we also showed that the data shows that there could be some potential impact on local control with patients who are node positive specifically. Of course, this is a secondary analysis and the trial wasn't designed to answer this specific question, so we definitely need to have this further validated in future clinical trials. And with that, I will turn it out to Dr. Horvitz, who will then focus on the radiation question specifically.
All right, thank you so much, Sep. Next slide, please. So our second abstract that we submitted was specifically focusing on the effect of the different radiation modalities on the outcomes. And why was this an important thing for us to look at? I think it's important to keep in mind that when this study was started, this was relatively early in the experience with use of intensity modulated radiation, especially for upper abdominal tumors. This had been validated as an important technique for head and neck and also for anal cancers, but hadn't been routinely used on studies for upper abdominal tumors. And just to think about the way that different treatments are given for 3D conformal radiation, you're defining ahead of time what your radiation beams are. And for cholangiocarcinoma or gallbladder cancer, you're using either 3 or 4 fields of radiation. And the dose of radiation that you get in the body is what it is. Whereas with intensity modulated radiation, you have to specifically define what your areas of risk are and what your targets are, and then you use a computer program to help determine where the radiation should come from and how the beam is shaped. And so you get very different distributions of radiation between these two techniques. And I think that that's an important thing to look at. Next slide, please. And so breaking this down at the baseline characteristics, similar to what Dr. Golami was talking about, these were relatively well-balanced cohorts, with the exception of female sex being more highly represented in the patients who received 3D conformal radiation versus intensity modulated radiation. And I think it's also worth noting that the vast majority of patients who were treated on this study did get IMRT. Next slide, please. One of the important things to look at is when you're carefully defining what your targets are, it increases the possibility that you might have a miss with the radiation because you're treating a smaller area. And so they did not demonstrate any difference in disease-free or local recurrence on these 2 different modalities when we looked at the 2-year numbers. Next slide, please. There have been several studies, most notably for different squamous cell carcinomas treated with chemoradiation, that patients who have a treatment break during their therapy have worse outcomes. And this had not been evaluated for different adenocarcinomas. And when we looked at the effect of treatment break, whether chemotherapy or in the chemoradiation arm, we did not see any effect on overall survival, disease-free survival, or local recurrence. And I think that it's important to note that the majority of patients were able to complete their therapy without a treatment break. Next slide, please. Next slide. Thank you. When we looked at radiation toxicity, we found that while there was no statistically significant difference between the 2 modalities, the patients who received treatment with intensity modulated radiation had a higher rate of grade 4 and grade 5 toxicity than the 3D conformal arm. And this is, well, again, not statistically significant, largely due to the small numbers seen on this study. I think that it's an important thing to keep in mind because the doses of radiation that were used to treat on the IMRT arm get right to about the tolerance levels of the bowel. And if you look at this, there was higher rates of GI ulceration and including 1 fatal upper GI bleed that was seen on the IMRT arm. And so I think that this is a noteworthy finding. Next slide, please. And so we didn't see a significant difference in disease-free or survival or local recurrence when these different radiation modalities were compared, which is important. Treatment break, again, was not correlated with outcome. And again, grade 4 and 5 toxicity was only seen on this study in patients who were treated with IMRT. And I think that this is in line with some other studies that have been recently presented that highlight the importance of radiation plan quality, not just that you're meeting your constraints, but that your contours are actually appropriate before patients start treatment. And so I think that this really highlights the need for prospective contour and plan review as part of radiotherapy trials going forward. With that, I'd like to thank you and open this up for questions.
Thank you both for first of all doing this work. You know, this is again highlighting 2 people who are extraordinarily motivated, utilizing resources within the SWOG infrastructure that exists, that anyone can access, and coming up with very high quality abstracts that accepted at national meetings.
Yeah, I think I had a question, Si, if we have a few minutes.
Yes, go ahead.
So where do we take this trial from here, right? You guys have done this really nice, analysis, and all the adjuvant trials in biliary are using chemotherapy only, right? And really, Bilcap's the only thing that we have. So do we approach now the issue of chemoradiation for adjuvant therapy? I mean, it's something that we discuss at our tumor boards on a weekly basis.
So I would say yes. I think that particularly based off of the primary endpoint, where they really showed that outcomes were equivalent between R0 and R1 resections, I think that that's a specific cohort that would benefit. But I think that that CEP's secondary analysis, looking at the results in node-positive patients, is particularly promising. And so I think that we know that those patients tend not to do well. And I think that demonstrating that these patients have a better outcome than historical controls with the addition of chemoradiation, I think is something that should be further evaluated.
Yeah, I thought to that end.
I think it's especially important. Oh, sorry, Sep, is that especially the Bilcap trial had only benefit in N0 patients.
Right.
So, Sep.
Yeah. Yeah, I thought it would be actually good as a next step, which I was going to suggest to present this to actually at the larger GI committee as well, with the hepatobiliary section is within that, and start really brainstorming whether we should forward. I do think there's some promising aspects of it in a very specific patient population, and we definitely have to define that, and then look at maybe specifics of radiations in which that should be further defined, I think, based on these information that we're getting. But it's worthwhile, and I don't know what Sai thinks about that.
Yeah, I mean, we have to kind of meet and come up with a proposal of where to take it before we present it, but I think it's a great idea. I had a quick question. I know we're running out of time here. So, Sep, if I understand correctly from your data, you demonstrated a decrease in disease-free survival with the use of radiation compared to historical control, but not overall survival. Is that correct?
Correct. Yeah.
So I guess I'm trying to understand how that occurs. If you're preventing recurrence of disease but not impacting survival, do you just think the sample size is too small to give us an accurate assessment?
Yeah, I do think there's enough data that suggests that if you are controlling DFS, that will ultimately affect your OS. I think there's enough evidence for that in various other tumors. So
if you,
I do think that. Yeah, I mean, we don't have 70 patients. It's not really a lot. If you have a larger population.
Right. I mean, I think that may be the angle to look at in terms of proposing something, is that you're impacting disease-free survival and that we weren't able to demonstrate overall survival because the sample size was too small. So that's something maybe we can talk at the next surgery committee meeting, to start utilizing the results of the secondary analysis to start actually designing a proposal. Great. Any other question from anybody? Well, with that, I want to close the session. We're 2 minutes over. I want to thank all the speakers for giving excellent talks, and I want to thank everyone for giving us 2 hours of your time. Hopefully people learned a lot from the lectures today, and for the studies that are ongoing and or being designed. I encourage everyone to keep track of them, and when they're available to open at your institution, please do so. Thank you very much, everyone. Flavio, any comments, last comments? All right, thank you.